HAP, varicocele, presentation and management. Varicocele refers to the abnormal dilation and tortuosity of the veins within the pampiniform plexus of the scrotum. It is a common condition, particularly in adolescents and young adult males, with an estimated prevalence of 15% in the general male population and up to 40% in infertile men. Clinical features. 1. Symptoms. Many patients are asymptomatic. Dull, aching scrotal pain or discomfort, often worsening with prolonged standing, physical activity, or at the end of the day. A sensation of heaviness or dragging in the scrotum. Visible or palpable enlarged scrotal veins, often described as a bag of worms. 2. Signs. Testicular asymmetry or atrophy, common in adolescents. Varicose veins visible or palpable in the scrotum, particularly when standing or during a Valsalva maneuver. May not be apparent when the patient is supine. 3. Fertility issues. Varicocele is a common cause of primary and secondary infertility. It is associated with impaired spermatogenesis due to elevated scrotal temperature, hypoxia, and reflux of renal metabolites. 4. Ultrasound findings. Testicular ultrasound with Doppler is the imaging modality of choice. Findings include dilated veins, 3 millimeters in diameter, and retrograde blood flow with Valsalva. 5. Grading of varicocele. Grade 1, palpable only during Valsalva. Grade 2, palpable without Valsalva. 3, visible on inspection. Management options. Management depends on the patient's symptoms, fertility status, and goals. 1. Conservative management. Indications. Asymptomatic patients without fertility concerns. Low-grade varicoceles that do not impact testicular function or size. Measures. Supportive undergarments or scrotal support. Avoidance of activities that exacerbate symptoms, e.g. prolonged standing or heavy lifting. Regular follow-up to monitor testicular size, symptoms, and semen parameters. Nest 2. Surgical management. Surgical intervention is considered for symptomatic varicocele, pain not relieved by conservative measures, infertility with abnormal semen parameters and no other identifiable cause, adolescent patients with testicular atrophy. Surgical approaches: open varicocelectomy, microsurgical subinguinal varicocelectomy, gold standard with the highest success and lowest complication rates, uses an operating microscope to ligate affected veins while sparing arteries and lymphatics. Inguinal varicocelectomy, similar to the subinguinal approach but performed through an inguinal incision. Laparoscopic varicocelectomy, often used for bilateral varicoceles, involves ligation of the veins under direct visualization. Percutaneous embolization, a minimally invasive technique performed by an interventional radiologist, involves occlusion of the internal spermatic vein using coils or sclerosants. 3. Post-surgical considerations. Recovery. Patients typically resume normal activities within a week. Complications include hydrocele formation, testicular artery injury, recurrence, or persistent pain. Follow-up: semen analysis after 3 to 6 months to assess improvement in fertility. 4. Management in adolescents. Indications for intervention include testicular atrophy on the affected side, symptomatic varicocele, potential future fertility concerns. Prognosis. Many patients experience symptomatic relief and improved semen parameters after treatment. Fertility outcomes vary, but up to 50 to 70% of infertile men see improvements in sperm quality after varicocelectomy. Effective management of varicocele requires individualized care based on patient symptoms, fertility goals, and clinical findings.